Without further ado, I will now hand you over to the Head of Research and Evidence at the HSE, Anna Therese. Thank you.
Thank you, Helena, and good morning, everybody. It's a great pleasure for me to have the opportunity to join such a great crowd to talk about the reform of the HSE Research Ethics Committees. So many of you attended the launch of the Research Governance Framework for the HSE that took place on the 9th of September. And at that event, we promised that there was going to be a number of information webinars coming up to explain how we were going to implement this framework. So today is the first of such information events. So basically the format of today will be about a half an hour presentation. We will have a few minutes break so that we can gather your questions. So please feel free to send us all the questions throughout the Q&A. We will gather your questions and then we'll have another half an hour in order to answer those questions. So without further ado, I'm just going to start sharing my presentation and we'll get going. Okay, so as I mentioned before, the HSE framework for the governance, management and support of research was recently launched, and this is an important foundational piece of work for the HSE because it represents the guidance document that we need to follow in order to develop infrastructure for research in the health services. So this document contains the principles for the governance management of health research in the HSE. It articulates the roles and responsibilities of the main actors involved in the research governance management support process. It contains the structures to put it into practice, and also describes the processes that we need to put in place to support staff. So as I said on the day, the implementation of the framework is not going to happen overnight. A number of projects of national scale need to be rolled out. And I just have them here on the slide. The first one is the reform of the HSE Research Ethics Committees. Then we need to establish the RGMS functions at local level. So RGMS standing for Research Governance Management and Support. We need to roll out the National Electronic Research Management System, establish the National RGMS Oversight Committee, and of course, develop relevant policies and standards code of practice so that we can achieve a cohesive approach as to how we do things. So today, we're going to talk about the first of those projects, which is the reform of the HSE Research Ethics Committee system. So before I can talk about what we're going to do, I'd like to explain a little bit about how things are at the moment, so the current landscape. As you all know, in 2021, so during this year, there was a transition of authority from the recognized RECS to the National Research Ethics Committee for the approval of clinical trials of investigational medicinal products, or CTIMs. So this committee commenced operations in May 2021, and they are responsible for the research ethical review of CTIM clinical trials for investigational medicinal products, as well as for clinical investigation of medical devices. So this was an important development in the overall scheme of things and will enable Ireland to comply with the European legislation with regards to clinical trials and medical devices. But those type of studies are complex, but they are a minority with regards to the overall research activity. So all the other studies that are not under the remit of the National REC are still the responsibility of the research ethics committees in the HSE and the HSE funded services. So obviously I'm talking here about health research. We did a scoping exercise a couple of years ago, and we have in the region of 32 committees, which approve in the region of 2,000 approvals per year. And of those nearly 2,000, about 100, so a little over 100, are the clinical trials and investigation for clinical devices. So you can see that the volume, huge volume of work still remains with the HSE committees. So in the HSE, we have a combination of regional RECs that have a responsibility for a regional area encompassing hospitals and community services. And in other locations, we have research ethics committees that are just aligned with the institution, and most of them are hospital-based. But in spite of the fact that we have so many committees, there are still many deficits. So there is large areas of community services, or CHOs, that have no access to research ethics committees. And things were already under pressure when we were hit with the pandemic. So COVID-19 really added a significant amount of pressure to a system that was already under pressure. And as a result, one of our regional committees, the Midlands REC, stood down and still is not operational. So that means that a large area of community services and hospitals have no access to REC. Also, there is by virtue of the fact that these committees operate independently, even though most of them are using the same application form, they have difference in approaches and different protocols, different memberships, etc. And in many cases, especially when these RECs are aligned with the single institution, a lot of demands are placed on the Research Ethics Committee in the absence of other structures to provide appropriate governance for research within hospitals, for example. And as you know, multiple approvals are required for those studies that involve multiple sites. So just to illustrate a little bit graphically the problem, this map here represents the color areas in the Republic are the areas of community services that have access to REC. But here the white area represents 3 different CHOs that where the community services have no access to research ethics committees, and yet there is 16 hospital-based research ethics committees. So you can see that the system is not perfect by any stretch of the imagination. So in order to fix all those deficits and to contribute to develop a cohesive mixed model of research ethics committees at a national level, we put together a working group, and this group is a large group of people that have a lot of expertise in this area. We have representation from a lot of research ethics committees within the HSE and Section 38 hospitals, representation from the National REC, the department, and other organizations. So the font is very small, you probably can't read it there, but so we've been working with this group of people over the last more than 18 months now at this stage, and together with work on a number of things, and one of them was to fulfill to finish this roadmap for the reform of the research ethics committees. So what are the objectives of this reform? Basically, we want equity of access, so that all of the HSE community services and all of the Section 38 and Section 39 services that do not already have access to a REC can have access to a REC. We want to create a more effective and efficient system so that we will have access to a single REC review for multi-site studies, because that will significantly reduce the amount of effort, the amount of resources, and especially the amount of time that it takes for a study to get started and get off the ground. We would like to enable a standardized approach to the review process, and also to integrate with other research ethics committees within the national system, as I mentioned there. It is also important to integrate the process of REC approval with other processes required for the overall governance of research, as we mentioned when we launched the research governance framework. And this is important to be done in a cohesive and organized way, as opposed to ad hoc, so that this doesn't represent more bureaucracy, but we contribute to streamline processes. We need to increase capacity to make sure we have enough research ethics committees to review all projects involving patients, service users, their data, or their samples. We need to increase consistency and the quality of the research ethics review. And ultimately, what we want is a sustainable research ethics committee system, ideally built on existing structures, and that is appropriately valued and respected and supported by the organization and the researchers. So I'm now going to talk about the proposed roadmap. This is going to be a phased approach. As you can imagine, the HSE is a very large organization and things don't happen quickly. So we need to do it in a phased approach to make sure that we can make appropriate progress. So the phase one of this project will involve the establishment of 6 regional HSE reference RECs, and these RECs will be aligned to the regional health areas as described in this launch care plan. So you can see the areas here in the map, and ideally these RECs will be developed from RECs that are already in existence, rather than developing new RECs when that is not necessary. So for some regions it will be necessary, but not from others. And as a result of the establishment of these 6 HSE reference RECs, so we call them reference RECs to differentiate them from the RECs that are already there. So we will have a full coverage for all of the HSE services and for all the HSE funded services, Section 38 and Section 39s that do not currently have access to research ethics committees. So what is a HSE reference REC? So basically these 6 regional research committees will operate to the same standard code of practice, management and governance, which is currently being developed by the working group. They will all be supported by the National HSE REC Coordination and Support Office. So this office is part of the National R&D Office, and again, is currently being established. And they will report to the National Committee for the Governance, Management and Support of Research that we mentioned when we launched the framework. And again, this is something that is currently being established. So I'm going to talk a little bit about each one of those 3 things. So the standard code of practice, what is this? Just by way of a summary, this will be a document that will explain the remit of the HSE reference RECs versus the remit of other RECs, for example, the national REC or hospital RECs or academic RECs, just to bring clarity not only for the research ethics committees, but also for the research community. So the document will articulate the governance and the management arrangements for these committees, details about membership requirements and arrangements to recruit members, financial considerations, how these RECs need to integrate with the research governance functions, what activities require REC review and what activities don't require REC review, and also it will contain an important section on the standard operating procedures, so that all of these RECs can operate to the same and have the same practices to achieve a cohesive approach overall. The Support and Coordination Office, as I said, will be part of the National R&D team, and we're currently proceeding with the recruitment of staff to manage this office, and this obviously will be very important in driving the implementation of the reform in accordance to the roadmap. This office will support the HSE Reference RECs with recruitment, with the training of the members, and also with implementation of all relevant operational protocols. It will be able to provide CPDs points for REC members as well. And importantly, it will develop a quality assurance program to ensure that all the HSE reference RECs are compliant with the standard code of practice. And of course, it will provide support with the electronic research management system. So this is a system that we plan to roll out over the next year or two. And it will be a national system that will enable that coordination between the research ethics side of things and the research governance side of things. And it will be an important addition to the infrastructure for research management within the health service. And finally, so the National RGMS Oversight Committee will become the REC appointing authority. So this committee has an important role in overseeing that the implementation of the research, the RGMS framework is done in a cohesive manner to end up with an integrated national system as opposed to ad hoc protocols being implemented in each one of the local sites. But in addition to that oversight role, they will have a governance role over their research ethics committees, and they will be their HSE Reference REC appointing authority. But they won't have obviously no role in ethical decision making. So this committee will be responsible for nominating the HSE Reference RECs for suspension of them if there is any issues or any problems. It will review the annual reports. It will ensure that these RECs are sustainable. It will ensure that the RECs comply with the standard code of practice, and they will drive the integration with other health RECs and cohesion with the National Research Ethics Committee. And very importantly as well, they will ensure there is transparency about how the RECs operate and the activity that they manage with the public and our patients. So this is, I suppose, in a graphical way, what it will look like with the Coordination and Support Office providing support to all of these, and the REC appointing authority overseeing the overall operation. So phase 2 will involve, phase 2 to 3, I suppose, will involve the establishment of agreed ways of working with other RECs to enable single approval for multi-site studies. So the 6 reference RECs will not operate in isolation. So as you saw in the earlier slide, there is at least 16 hospital RECs based in the Dublin area alone. So there is, I think, at least 20 hospital-based RECs that we will need to work with to make sure that we end up with an integrated, cohesive approach. So the HSE Reference RECs will have the authority to approve multi-site studies, but that will involve that protocols, ways of working will need to be put in place to make sure that communication exists with the different local sites, especially until the research governance functions are established at local level. So communication with the existing RECs in terms of sharing documentation, sharing information, and agreeing protocols to make sure everybody's in the loop and the governance aspects of the research don't fall through the cracks. We will also like to establish, I suppose, engagement with the research ethics committees from private hospitals, because often the research is a collaborative activity that is not ring-fenced to public services. So it's often the private hospitals are also partners as part of the research projects, and we need to include them in the picture. And then, of course, we have the universities. So generally, a university, when it's an academic member of staff doing a research project involving the HSE, you require 2 ethical approvals, one from the university and one from the health service REC. So we would like to engage with the universities and see if there is any way to simplify the protocols, even if two REC approvals are still required, there could be a way to simplify the protocols while maintaining appropriate governance for the research activity. So now I'm going to talk a little bit about each area and how we plan to do this for each regional health area. So the regional health area E is in the northeast, is Monaghan, Cavan, Meath, Louth, and Dublin North. And it covers all of CHO9, some parts of CHO8, and all these hospitals that I have here. So the hospitals belong to two different hospital groups, the Irelandese Hospital Group and the RCSI. So the Irelandese are the ones in blue, and the RCSI are the ones in green. And at the moment, there is a regional research ethics committee already serving most of this region, which is the HSE Northeast area. And in the left-hand side, you see the hospitals that are currently being served by that committee. And on the right, you see us hospitals within this region that have their own research ethics committee. So in the new system, the HSE Reference REC for this area will expand the coverage to include CHO9, which at the moment has no access to our research ethics committee. So in regional health area B, which is the Midlands, this area covers all of CHO7 and part of CHO8. And these hospitals here at the bottom of the map, some of them have their own REC, and some of them used to be covered by the HSE Research Ethics Committee in the Midlands, which unfortunately stood down during the COVID-19 pandemic. So this area at the moment has no Research Ethics Committee, and we're actively trying to reestablish that committee as we speak. So in the new version of this committee, this will actually, I suppose, give us the opportunity to establish the first HSE reference REC in the Midlands, and will expand coverage to include CHO7, which currently has no REC cover, and it will also include cover for all the projects in the corporate HSE, so the corporate division, and also the national services, which at the moment they don't have an obvious REC to go to either. Okay, so for regional health area C, so this is the southeast, and is Wicklow, Wexford, Carlow, Kilkenny, Waterford, Tipperary South, and Kilkenny. I mentioned one of those twice, but anyway, it basically covers all of CHO5 and CHO6 and all the relevant hospitals. There are 10 hospitals in this area, including hospitals from the Irelandese Hospital Group and the South-Southwest Hospital Group. And at the moment, the majority of this area is covered by the HSE Southeast Research Ethics Committee. And in this area, there is also a number of hospitals that have their own research ethics committee, which you can see here under the map. So the HSE, the new HSE reference REC for this area will evolve from the existing REC, and that will require an increase in cover to include CHO6, which currently has no REC cover either. So for the regional health area D, this is the area of Cork and Kerry, and includes all of the CHO4, and all the hospitals belong to the same hospital group, the South-Southwest Hospital Group. And currently this area is being served by the Clinical Research Ethics Committee of the Cork Teaching Hospital. So this is an academic REC that is aligned to the Cork University. So the establishment of the evolution of this committee into a HSE Reference REC, obviously it will require some agreement with the university, but it will mean not necessarily a change in their geographical cover, but they formally will take over research that comes from the community services in this region. So for Regional Health Area E, this is the Midwest and includes Clare, Tipperary North and Limerick. This area covers all of the CHO3 and the hospitals in the UL hospital group. Basically, the regional HSE Research Ethics Committee that is already there, is already aligned, and it already provides cover for all the hospitals and all the community services in this area. So if there won't be any change in geographical cover for this committee. And then finally, for Regional Health Area F, so this is all the west and the northwest, includes Galway, Mayo, Roscommon, Sligo, Leitrim, and Donegal. So in this area, we have all of the hospitals of the Ciolta group, and also cover CHO2 and CHO1. And so this is, I suppose, is different to the other regions that I spoke about, in that there is a number of, there is no regional REC, but there is a number of RECs associated to hospitals. So this includes the RECs in Galway University Hospital, in Letterkenny, in Mayo, and in Sligo. So the format for this region still hasn't been, I suppose, agreed at local level. So it could be take a variety of forms. Since all of the committees in this region are from HSE hospitals, you could merge them all into a single REC, or you could have one of those research ethics committees, possibly the one associated with Galway University Hospital, since it's the largest in the region, becoming a HSE Reference REC, and then liaising with the other committees, whether it's in a hub and spoke model or in a similar model as I mentioned before, by way of agreement. So basically it still needs to be decided. So then there is a phase 4 and 5 also of the reform. This is a long term, and it's a little bit aspirational, but I don't want to forget that the possibilities to do this are still there, and the real possibilities whereby eventually you could have a system whereby all of the hospitals are RECs may be operating to similar standards, and therefore could be mutual recognition between the HSE Reference RECs and the hospital-based RECs. And eventually you could aspire to have all of these RECs operating as part of a single national system, similar to the way they operate in the UK. With regards to the timeline for the implementation of this, so in 2021, this year and last year, we were working on the standard code of practice and governance, and that's nearly finished. So we will hope to be able to make this available in our website before the end of this year. As I said, also we are also recruiting to establish the National REC Support and Coordination Office, and working also on the establishment of the REC Accounting Authority, which is this RGMS National Oversight Committee, which we hope to have established this year, with the view to start operations at the beginning of 2022. So then Next year, we hope to establish the 6 HSE Reference RECs and support them so that they can operate to the standards articulated in the Code of Practice and provide a service to all the different organizations that require their support. We would like to establish those protocols with the RECs in the hospitals to make sure that we have an integrated and cohesive system, and agree with the private hospitals and the universities. So ideally, the bulk of this work will happen in 2022, but inevitably, I think it will spill into 2023 as well. So just before I finish my presentation, there is obviously a number of issues that are of immediate concern. With the lack of research ethics committee in the Midlands, there is a large portion of our community services that have no access to a REC. So, during the pandemic, we managed to work with the Research Ethics Committee in the ICPG, who thankfully helped us to provide cover for 1 year. But I suppose we had hope at this stage that the committee will be maybe resurrected and that the pandemic will be well behind us, but it keeps dragging on. So unfortunately, the REC and the ICPG can't continue doing this, and we just need to reestablish this committee from scratch. So that is one of our main priorities right now. So the pandemic as well has put a significant pressure in the Northeast, and we are actively working to support that committee in the interim until we're in a position to establish it properly as a HSE Reference REC. So I suppose I couldn't miss the opportunity to try and recruit some of you. If you're in the audience, are you interested in becoming a Research Ethics Committee member for the REC Reference REC for the Midlands? We're looking for all kinds of members, experts, lay members, patient representatives, and also the role of the chair and the vice chair. So we'll be absolutely delighted to hear from you. So the information for this campaign is in our website. You can get the leaflet and the expression of interest form from our website. So that is all for me now. So what we're going to do is we're going to take a few minutes break, and we will take a 5-minute break just to gather the questions, and then we'll answer your question after that. So don't go, go and get a cup of coffee or something, and we'll see you in 5 minutes. Okay. Hello, hi everybody, we're back again. And I'm going to be joined by my colleague, Declan O'Hanlon. He is a member of the National Research and Development Office, and he will ask me, he'll be your voice today, so he'll be asking me your questions. So hopefully we'll get through as many of them as possible over the next 20 minutes or so. Thank you, Declan.
Very good, thanks, Anna. So we've had a series of questions through here, and we'll try and work through some of them. Some were very, I suppose, specific with regard to local issues, or might have involved individual projects or protocols. So if you've included contact details in your answers, we'll try and get back to you on those. If you haven't, and also if we don't get to your question, you can also email it through to hse.rec@hse.ie, and we'll get back in touch. So we'll kick off then. And first question then, Anna, we might start with, will the same supports and training be available to the Section 38s?
Okay, so obviously the objective of the Coordination and Support Office initially will definitely be the HSE Reference RECs, but it is anticipated that some of the activities, by virtue of the fact that the activities could be open up to other research ethics committees, we see a role for this office expanding their support to the hospital-based committees, for example, for training for the REC members, if we are doing recruitment campaigns, or any other support, for example, with the electronic research management system. The idea is that initially it will be just for the reference RECs, but over time we would like to expand it to the hospitals as well.
Very good. Next one in. Is any distinction planned between ethical approval processes for health and social care research?
Well, health and social care research is all part of the remit of the HSE reference RECs. So any research that involves HSE patients, whether it's health or social care, if it involves patients, service users, if it involves their samples or involves their data, it will be under the remit of either the NREC or the HSE or HSE funded organization RECs. Yeah.
Thank you. Next one then. How do we ensure compliance with the standard code of practice? Will the RECs be subject to audit?
Okay, so the National Coordination and Support Office is going to develop a quality assurance program. So I don't know the answer to that just yet, but I presume that assurance program will involve some sort of a reporting mechanism whereby the research ethics committees will have to report on an annual basis to the appointing authority through the office. And might include some audits here and there, but that is still to be designed, I suppose. Yeah.
A further question then with regard to the standard code, will there be consultation on the standard code before it's finalized?
Well, the standard code, as you saw, the working group is quite extensive. There is about 20 people in it, so I'm not sure if we are going to put it out there for external consultation, but it is possible that I suppose if we will aspire that other RECs would like to join in the bandwagon and follow the same code, it's only fair that they have a voice. So I will bring that to the attention of the working group and see if we can include around a consultation with other research ethics committees, for example. Yeah, that's a good idea.
Very good. Following the establishment of NREC, what then determines who will be a regional REC or just a REC?
Okay, so the regional at the moment there is regional RECs and hospital-based RECs. So the regional RECs are going to evolve into the HSE Reference RECs, and the others will remain hospital RECs. So basically the difference, I suppose, between the HSE Reference RECs and the others is that the HSE Reference RECs report to the appointing authority, and they will be given the authority to approve multi-site studies on behalf of all the other hospital RECs, while the hospital RECs at the moment, they won't be able to do that, but they will still have their own authority to approve their own studies happening in their own site.
Another question then with regard to reference RECs. Will the reference RECs replace the existing local hospital RECs?
No. So the idea is that there will be one HSE reference REC for each regional health area. And within that area, the HSE reference RECs will need to establish protocols to work with the individual hospitals to make sure that, for example, when they are approving a multi-site study, there is a single research ethics approval required, and that will be given by the HSE reference REC, but that there will be communication with the local RECs at local level to make sure that the governance of the research doesn't become impacted by the new protocols. But they will continue to exist, yeah.
Next one in then was having mutual recognition across RECs for non-CETAM applications will be hugely helpful and encourage more people to get involved in multi-center studies. What steps do we need to put in place for mutual recognition across the RECs?
So I suppose mutual, we can get over the problem that we currently have with regards to multi-site studies by giving the HSE Reference RECs the authority to approve multi-site studies. And obviously the reason why we could do that is because we can stand over the quality of the protocols that are taking place in the HSE Reference RECs. Now, mutual recognition will mean that each one of the hospital recs will also be able to do the same. So we're not there as yet. That's part of, I suppose, the next stage, phase 4 or 5, and we still don't know what will be required to do that. But obviously, all the recs will need to be operating to similar standards in order to achieve that level of, you know, mutual recognition. So there is still a bit of conversations to be had in that regard.
Okay, a question here then about resourcing. On your slide, you mentioned sustainability. Does that mean there will be funding and admin resources provided to RECs, or is there an expectation that regional groups will fund the same from their own resources? I understand that there have been ongoing challenges for those involved with regard to being sufficiently resourced.
Yeah, well, that's one of the major problems at the moment. The research ethics committees are significantly under-resourced in the HSE, and that is something that for the HSE Reference RECs we aim to address. So we have put together a bid for resources through the HSE department mechanisms, and we hope to be successful, but obviously we can't set up this system without resources. So the HSE Reference RECs need to be properly resourced, otherwise they won't be able to operate. Yeah.
A question here just asking for some further clarification. Will all studies have to get REC approval? What about, for example, students surveying staff?
Okay, so we're talking just about health research. So there is many different types of research that may involve, I suppose, staff, but they're not health research. So you may have a business study, for example, but we're talking about health research, and we're talking about studies that involve patients, that involve staff, that involve HSE services, that may involve health service users in any way, patients' data or patient samples. So if your study involves any of those, yes, you require research HSE reference or REC approval. Yeah.
There are one or two questions then just in about the committees and membership. Who is eligible to sit on a committee? Does it have to be doctors and nurses?
Okay, no. So the code of practice that we're putting together has a section with regards to the membership, and there has to be representation from both clinical and lay members. So the clinical staff can be doctors, nurses, health and social care professionals, but then you have lay members that don't have to be clinical, and you also may have university researchers, people with expertise in ethics or statistics, for example, but then you may have lay members that don't necessarily have expertise in research or but may bring other expertise to the table. And of course, part of the lay membership will include your PPI representatives that will bring the patient voice to the process, and which is also very important.
A related question then, can you apply to be a member of a REC in the Midlands if you're based in a service in Limerick?
Yes, you can. So basically at the moment, in the past, all the meetings took place physically, but I suppose COVID-19 has, I suppose is probably the only good thing that has enabled us to develop new ways of working. And we anticipate that the new committees will facilitate hybrid approach. So it might be some physical meetings, but certainly remote presence will also be enabled. So you don't necessarily have to be in the same region of the committee that you're sitting in.
A further question then just about the Midlands. There are many HSE organisations that have no access to a REC because the Midlands REC is not operational. What are researchers expected to do in the interim?
Okay, so that's a hard question, and I do apologize that I don't have a good answer to that. So we are going as fast as we can in trying to resurrect the Midlands REC, but we are aware that in the interim, the researchers have no access to a REC. I anticipate that the new Midlands REC incorporate in some areas. So I think the Midlands REC, once established, will cover other areas that don't have a REC in the interim as well, until the other HSE reference RECs are established. But that's not going to happen until, I suspect, January or February in next year. So in the interim, we really don't have a solution. I mean, we have tried to engage with other RECs to see if they were able to provide support, but at the moment they really are under severe pressure and they weren't able to offer assistance at this moment. But by all means, if there is any research ethics committees in the audience who would like to lend a helping hand for the next 3 months to support this area, please get in touch with us. I'll be really grateful.
A related question then, just again on resourcing and with regard to REC membership, it asks, will the members be remunerated?
Right. So at the moment, the participation as a REC member is not remunerated, but we are looking at the possibility of remuneration for the role of the chair and deputy chair. Now, so there is complications where the role of the chair and deputy chair is held by a staff member. There is no mechanism to pay the person who is already in public service twice, if you know what I mean. So at the moment, we are encouraging people who are interested in taking on those roles to do so as part of their working hours. And we would like to encourage, if there is any managers in the audience, to support staff that put their hands up to take on these roles and giving them the extra time that they need during their working day to do this during their working day. Now, I am fully aware that that's not very realistic for some professions, but otherwise the work is not remunerated, and we are, we know that the involvement of the chair and the deputy chair will be time consuming, much more than for the other REC members. But by and large, the participation is voluntary. So we're also, I suppose, waiting for the department. I know the department are looking at an approach for the remuneration of PPI representatives remuneration. So we're just waiting for guidance, and when the guidance is produced, we will follow the guidance. Yeah, and we'll also be able to offer, I suppose, if we can't offer remuneration, I think it's still worth being a member of the committee for other reasons. Even though it involves a little bit of work, it gives the members an opportunity, I suppose, to learn about research, to contribute to ensuring that the research that we host is underpinned by ethical principles, and to improve the quality of the research. You will have access, I suppose, to a network of people as part of the other REC committee members. That could be quite useful to you. And we will also support staff with the CPD points for attendance to the REC committee meetings, and also for attendance to the training sessions. So
very good. We might have time for 1 or 2 more questions then. Some here just in the context of multi-site studies and maybe interaction with other RECs. So I have one here. If I have approval from a university REC, do I still need approval from a HSE REC?
You do. So if you're, as I said before, if your study involves patients in any way, or service users, or involve HSE services or HSE staff or HSE patient data or samples, then you need approval from a HSE REC. In addition, to the university REC. So as I said in my presentation, we aspire to link in with the university sector to see if there is a way to simplify the approval protocols so that, you know, even if you require 2 REC approvals, that could be as expeditiously as possible.
Okay, then in the context of multi-site studies, you said that the HSE Reference RECs will be able to approve studies involving multiple sites. Once the HSE Reference RECs are in place, how do we know which REC to apply for multi-site studies?
Okay, so the HSE Reference RECs will have the authority to approve multi-site studies, and ideally, when you should apply to the REC that is servicing one of the sites. So if that is not possible, you'll be able to apply to any of them. Yeah.
And maybe a related one then, how will hospital RECs, which are not HSE RECs, be informed that studies are taking place within their sites?
Yeah, so that is part of the phase 2-3 of the project, where so once the HSE reference RECs are established and are given the authority to approve multi-site studies, that communication with the RECs in Section 38 hospitals or HSE hospitals for that matter need to be done. So I think at the moment we are planning to reach out to them. So probably this is going to happen within the next month, I say, or the next few weeks. We're planning to reach out to the hospital RECs to discuss this and to see what they feel should be put in place.
I think we've just time for one more then. Will the roles and responsibilities of the RECs change with the new system or remain the same?
Well, the role of the research ethics committees, I suppose in many cases, especially the ones that are aligned to hospitals, has actually grown. So the research ethics committee is meant to have responsibility for the ensuring that the ethical aspects of the project are above board and the dignity and rights of the research participants are protected. But because in the absence of other governance structures, I suppose they've taken more responsibility, or they've been given more responsibility. But the research governance framework articulates that the RECs are responsible for the REC business, but yet it is the institution that is responsible for other governance aspects of the research. So not sure that answers the question, but basically, so the HSE reference RECs will just have responsibility for the research ethics side of things, and the institutions will have a responsibility for the governance of the research that is taking place within their premises.
Thanks, Anna. I think we'll have to leave it there then.
Okay, but that's great. Thank you so much for all of the questions. And by all means, if there was any questions that we didn't get a chance to answer, or that you think afterwards, you can send us to hse.rec@hse.ie, or just Google us and find us on our website, and there is other email addresses there that you can use to contact us. So just to remind you that we are having another information webinar coming up on the 2nd of December about the implementation of the RGMS functions, and we hope to see you all there. Thank you so much for engaging with us today.
Thanks very much.
Bye. Bye-bye.